Thank you very much. Thank you to the chairperson. Thank you, Dr. Mohan, and thank you to the organizers. And above all, thank you to the audience. So I'm going to change gears a little bit and really talk about the in thing about type 1 diabetes management and also coming into type 2 diabetes is the so-called artificial pancreas. So these are my disclosures and conflicts. The learning objectives, three major ones: review of the landmark clinical trials of AP or artificial pancreas over the last 5 to 6 years, recent advances in artificial pancreas approaches, and future directions and challenges. I would like to make this a little more interesting. So, we as diabetologists prescribe insulin almost every day. How do you define 1 unit of insulin? Anybody? So you prescribe insulin every day, right? Do you know how much is 1 unit? Okay, I'll give you the answer. It is 1/3 the amount necessary to cause hypoglycemic convulsions in a 24-hour fasted rabbit weighing at least 2 kilograms. So it's all about insulin causing hypoglycemia, the danger of insulin. So it's equivalent to so much milligrams of crystalline insulin powder. So now from the sublime to the ridiculous. So I'm going to eventually go into artificial intelligence in AID, which is automated insulin delivery. So we look at the timelines over the last 50 or 60 years. Initially, all of these closed loop systems, and Abhishek, who's going to be the next speaker, he's an engineer, control engineer. He will probably tell you that all of the previous closed loop system or the existing closed loop systems are equation driven. The proportional derivative, PID, MPC, or the model predictive control, etc. They're all based on equations derived from human physiology, and we'll talk about that. Eventually, now it's coming into more data-driven control using artificial intelligence with the so-called neural network systems. Again, I'm not an engineer. I'll let the engineers discuss this in more detail, but it is really the next generation of technological advances to manage type 1 diabetes. We contributed, Rita and I contributed to the development of the closed loop systems by getting all the database for human physiological data for carbohydrate metabolism. When we studied more than 200 people between the ages of 18 and 95 at Mayo Clinic when we were fellows and junior faculty, to understand human carbohydrate metabolism and hormone physiology. And then that data was generated to form the first type 1 diabetes simulator, which is an in silico model that the FDA endorsed in 2008 to replace costly and time consuming animal trials. So over the last 6 decades, there have been multiple advancements in the so-called artificial, automated insulin delivery or closed loop systems. I will just enumerate a few landmark studies. The first such study was published in 2019, which was a 6-month randomized multi-center closed loop trial to control type 1 diabetes. And the lead author was Dr. Boris Kovachev, whom we collaborated with while at the University of Virginia. So the objective of this pivotal trial was to generate safety and efficacy data satisfying FDA requirements for approval of these closed loop systems. So there were multiple sites. I won't go into the detail of that. So, but the important thing is to look at the study flowchart. So they enrolled 170 participants, randomized 168, and over a 6-month period of each participant, every one of the enrolled participants completed. So that was a remarkable achievement for type 1 diabetes randomized control study, that every subject who was enrolled completed the study. And they were divided 2:1 into CLC or closed loop control and SAP or sensor augmented pumps. That means the sensor was there, the pump was there, but the sensor was not talking to the pump. The human being behind it was making his or her own decisions. So when you look at the results, that there was and we'll talk about time in range, or the percent time in range, basically is the average percent within a 24-hour period that the CGM glucose is between 70 to 180 milligrams per deciliter. As you can see with the closed loop in pink or in orange, within the first 1 month, there was a clear separation of time in range. Time in range was higher with the closed loop than with the sensor augmented pump therapy. Glycated hemoglobin also separated early on, and over a 6-month period, there was a clear separation of hemoglobin A1C. But the more important things were probably apart from the increased time in range, is that hypoglycemia was in fact decreased by this closed loop therapy, because prior to closed loop therapy with the DCCT and other trials using injected insulin, you can achieve better hemoglobin A1C, but at the cost of hypoglycemia. The more insulin you use to control hemoglobin A1C, the higher the risk of hypoglycemia. The closed loop systems abolished that paradigm, saying that despite having better glucose control and lower hemoglobin A1C, the risk of hypoglycemia was actually mitigated, not increased. So to summarize, 100% of participants completed the randomized control trial and were actively using the system at the end of 6 months. The closed loop system was superior to sensor augmented pump in all glycemic control parameters, and the results were consistent across a wide range of hemoglobin A1C. Doesn't matter whether the patient, when they entered the trial, had a hemoglobin A1C of 5% or 10%. Their improvements were similar. And participants reported a high rates on ease of use, trust, and usefulness of the closed loop system, because that is one of the very important things, is that the research participants or the patient has to be comfortable with the technology that they use, because remember, they're relinquishing their normal control to a machine. Next, I will just briefly talk about a few randomized control trials in children. This was also published in the New England Journal of Medicine. It's a 16-week multi-center open loop parallel group trial, children between the age of 6 and 13 years, and randomized 3:1 into either closed loop control or sensor augmented pump. And again, as in the previous study in adults, there was a clear separation. The time in range was higher in children over the age of 6 than the control group. And in all these clinical trials, as you will see now, on the x-axis is the time of the day, midnight to 11 p.m. So really, as you will see, in the overnight period, the time in range approaches 95%. What does that tell you? That means when you're not eating, it works perfectly well. When you eat, other things happen. So then the time in range falls. So with the newer and newer systems, this percentage is going up and up. The time in range is going up and up, and I'll discuss that briefly. Again, there was another study in very small children between the ages of 1 and 7 years. So these are really infants and toddlers with type 1 diabetes. And this study showed also that closed loop insulin delivery had lower sensor glucose measurement in red than the sensor augmented pump therapy. So really, with these closed loop systems, patients with type 1 diabetes above the age of 1 year would benefit from these closed loop systems. What about faster insulin or other adjunctive therapies? Because so far I've talked about just insulin only closed loop. So there are faster insulin, as you know, insulin Fiasp and Lyumjev. There has been a study that was published by Roman Hovorka from Cambridge, UK, about 3 to 4 years ago. It was a double-blind, multi-center randomized control trial comparing the regular insulin aspart to the faster insulin aspart. Basically, it showed that Fiasp is safe and effective compared to aspart, with added benefit of hypoglycemia reduction. So again, giving these faster insulins perhaps reduce the risk of hypoglycemia than the conventional aspart or Humalog insulin. What about adjunctive therapy? So a few years back, we published a paper, we did a clinical trial where we used low dose empagliflozin, 5 milligram of empagliflozin versus no empagliflozin with automated insulin delivery, either the closed loop system or a low glucose suspend system. Again, for the interest of time, I won't go into the details, but basically what we showed was that just with 5 milligram of empagliflozin, which is a very low dose SGLT2 inhibitor, the time in range almost reached 100% in these patients with type 1 diabetes compared to no empagliflozin. So really adding a low dose SGLT2 inhibitor, again off-label use because SGLT2 inhibitors are not approved for use in patients with type 1 diabetes. And the same outcome was true whether we used the fully automated closed loop systems or the low glucose suspend. With the low glucose suspend system also, the time in range increased significantly with empagliflozin. But there is always a but. Out of the 32 patients that we studied, ketosis remains a challenge. So we had one patient out of the 32 that developed diabetic ketoacidosis on even the low dose empagliflozin. So clearly, more studies are needed to evaluate the effects of empagliflozin, perhaps with the use of a continuous ketone monitor, which, as you know, certain companies are coming up with. And I know there are trials in the United States using the continuous ketone monitor, apart from a continuous glucose monitor in these closed loop systems with low dose empagliflozin. There was another trial by Ahmed Haider from Canada that also showed low dose empagliflozin up to 2.5 milligrams, which is really a very low dose, does show improvement in glucose control in the closed loop system. A few other studies I will discuss briefly is the multi-hormone, because as you know, diabetes is not just because of low insulin. Glucagon is also abnormal and other hormones could be abnormal. So there has been a few studies looking at dual hormone closed loop systems, insulin and glucagon. This was by Jessica Castle, and it showed that single hormone versus dual hormone closed loop systems do perhaps improve and reduce the risk of hypoglycemia, but these are only very short-term studies. So dual hormone closed loop system reduces exercise-related hypoglycemia, increase mean glucose and time in hyperglycemia compared to single hormone CLC. But glucagon, as we know, is not a benign hormone. It does slow down gastric motility and can cause nausea. So glucagon-induced nausea was a significant factor leading to withdrawal from study in three patients. It was a very small study. Hans de Vries from Europe also did a fully closed loop glucose control with a bihormonal artificial pancreas. This was published in Diabetes Care a few years ago. But again, as you will see, it's a complicated study with a lot of hardware. The pump has to have both insulin and glucagon pumps. There's two sensors, two insertion sites. So it's a complicated system and it's not very user friendly. Another hormone that has also been tried together with insulin is pramlintide. As you know, pramlintide or amylin is co-secreted with insulin by the normal beta cell. So there have been multiple studies that have shown that perhaps insulin-pramlintide combination can do better with insulin alone. But these are early days yet, and further studies are needed. Recent literature. This was a meta-analysis of a randomized trial outcome from the for the control IQ system, which is a MPC system that showed that really closed loop systems do better in the real world as well. For the interest of time, I will rapidly go through and talk briefly about the neural net artificial pancreas. So neural net artificial pancreas is a new algorithm based system that is coming into the fore, and the first of his studies were published recently by Dr. Boris Kovachev and his group at the University of Virginia. So It is a process by which the action of any insulin dosing rule, including automated insulin delivery algorithms, can be reproduced by your neural networks. It's almost like an artificial brain that uses artificial intelligence to devise new algorithms. And the beauty of that, the neural net program can actually be trained in real time or by in silico data. And the neural network can approximate the insulin dosing rule at any level of precision, generally depending on the network complexity. Again, I'll let Abhishek explain that in the next talk. But basically, they did a randomized control trial that was published, I think, 2 to 3 months ago, that showed, compared to the model predictive control on the left, which is the standard approved devices, the neural net, the first study of the neural network artificial pancreas didn't do any worse. In fact, they were equivalent. So what are the important differences between current algorithms versus neural network? In the current algorithm, learning or adaptation relies on data patterns of the user, while neural network can tap into the data science, the large body of data that is present, that is currently available with the use of CGMs and pumps. The neural net can tap into that. And in the current systems, any learning or adaptation of algorithm requires substantial computing power, which is very important, as the engineers will tell you. Most approved AIDs cannot run on complex nonlinear algorithms and cannot tap into large available databases involving data science. So the current algorithms that are there can use their patient's own data as experience and learn from that. The neural network can learn from the variety, large body of data that is currently present. And the important thing that an engineer will tell you, that the computational demands is 6-fold lower with the neural network than with the current established systems. So clearly, this is probably the future of closed loop algorithms. What are the studies that are currently happening that I know of that are in the pipeline? We are doing a study of artificial pancreas on physiological changes to carbohydrate metabolism during and after puberty, after solid organ transplants, AP with hypoglycemia unawareness, AP using continuous ketone and lactate sensor, multi-hormone AP studies, and eventually fully automated closed loop studies. There is one study that I want to briefly mention about, is the Forget Diabetes study, which is a bionic invisible pancreas. It is immuno-optimized, fully implantable, fully automated AP with intraperitoneal glucose sensing and insulin delivery. Insulin refills via weekly oral recyclable insulin pill. So that is currently happening in Europe. And the other, the future is, of course, accessibility of artificial pancreas across all sections of society and across the world. I'll end with Alan Turing's comment: a computer would deserve to be called intelligent if it could deceive a human into believing that it was human. Thank you.